Side of personal life, did you go to Malaysia? Did you go to the Fix Congress?
I did
How,
for
how was that?
ultimately. It was great. It was awesome. I've not had much exposure to Fix. I'm not sure what your experience has been with that organization, but I know Martin very well. He was one of my teammates when it came to our Swedish rock tape team. So I've had years of knowing him and respecting what he's done, and so him being the president and inviting me, I didn't bat an eye at it. But the problem was I didn't think about the travel and just all of the requirements to be able to do an event like that. And I literally went there for the weekend,
Oh
which
wow,
was not what I would recommend for anyone to do.
not a good suggestion.
No.
And for those that are listening, if you're just like, what are these two bros catching up about? So the Fix is God, I'm probably gonna butcher this. I'd have to go look in my room at the sheet, but the Federation International Chiropractic Society, but it's not even in English, so I'm butchering it anyways.
Right.
That's what we were talking about. There was a congress in Malaysia a few weeks ago, but the focus there was fascia was a center point around that talk. Am I wrong on that? Or
No, it was. The keynote speaker was Antonio
yeah,
Stecco, which gave a great synopsis on what the evidence is indicating as it relates to fascia for manual therapists in general. And this was focused more around sport chiropractors, international sport chiropractors that work around the world, and just kind of leveling up our understanding of how the system interacts with everything that we do, from a chiropractic adjustment to joint mobilizations to soft tissue management. So it was just a great weekend of information from Antonio, and then we had multiple other speakers just contributing to the conversation of how we could better interact with our patients and clients.
any like groundbreaking takeaways, like things that were completely foreign to you, or just kind of did it like re-emphasize anything?
It re-emphasized that dosage does matter. Having an understanding of what the intent of the treatment is. Are we focusing on the mechanics of the tissue and looking at, can we influence the fascial network as it influences nerves, tendons, ligaments, recovery? So that was helpful to kind of get the science to be able to reaffirm that dosage does matter. But the secondary conversation is looking at the human that we're actually interacting with. And so it was really refreshing to start to have the conversation that we are interacting with a complex being. What are those psychosocial components that we should be considering as it relates to our soft tissue therapies, our joint manipulation therapies, and our rehab?
Which I think is, I don't know, I'm not going to say this in an eloquent way. It's not that we give it lip service. We all know that, but then we'll go about our business as usual, right? Somebody could literally say, I've been adjusted and it just was not my favorite thing in the world. And hesitancy. And we're just kind of like, yeah, but like we're different and we're going to do it better. And so I found myself, guilty of that, but I try to tell people now because of, in particular, my interactions with either people that have had a bad experience or kids with dry needling, right? Like there will be a huge, anxiety experience with them. And I'm like, if that's the case, you're literally going backwards on the treatment table. Even if you think that is the best, therapeutic intervention, it's not the best organismal, intervention or jumping in point. So I kind of always just say is like, match the treatment aid to the whatever, it's a pathoanatomical diagnosis or your functional findings, but also match to the person. Because even if somebody the other way too, right? Somebody tells you, man, I have had amazing success with ART, and you might think ART is the dumbest thing you've ever heard of. You better pay attention to that. It's got power.
Of course. And so, like, again, just to kind of double click on what we were just talking about on just what we're gaining in respect to information. The psychosocial conversation or the biopsychosocial conversation has been around for decades. And yes, I've not met a clinician, at least in the category of clinicians that I generally speak to, that's ever said that they don't believe in the idea of biopsychosocial. So everyone trusts that that is the model that should be at least entertained when you're dealing with a human being. But what we're finding, and this was echoed at this symposium and others, and this past month, the month of March, I was probably at 3 different symposia and had the opportunity to kind of get the temperature of what the conversations were. And consistently, the biopsychosocial concept presented. And I think it's pertinent to our discussion today, at least what I think we're going to be talking about today. But so let's say we agree that biopsychosocial matters. I think the next step really comes down that we have to accept the fact that our formal training, anyone in manual therapy, generally focuses attention on the biomedical, approaches. What can we do with our hands, with a tool or an instrument, technology to be able to influence said tissue or said area of the body? And we do agree that the psychosocial component is important, but what we're not provided as a general rule is what is the roadmap to be able to implement those components that is uniquely specific to the individual that you're working with. So to your point, we agree, but we may not have all of the confidence as therapists to be able to deploy. And that's where I think we need to start to gain more insight from those that have been doing it for many years, get the experiential side, and then also get what the evidence is telling us now of new and novel ways of interacting with the psychosocial component. So that's where I've been focusing my attention over the last, let's say, 5 to 10 years, because as you get further along in your career, at least my experience has been this, that I get presented with more and more complex cases, which challenged me to be able to think outside of the box of the general manual therapy approaches that I was using, the dosages that I thought were effective for someone else's case just wasn't working with this individual. So what should I be thinking? And so that got me starting to think heavily towards the psychosocial component. And I've had some success to be able to integrate some of those into my current practice regime.
Which we'll definitely dig into. The kind of cool through line already is, you and I had we'll call it part 1, even though this will probably be a completely separate and succinct conversation, on, Jay Shaw's kind of big review on, trigger points then and now. But the through line is kind of reverse what you just said on the, the BPS side of things, that we know that, right, that approach, this concept is important. We're probably undertrained, and then via the undertraining, lack confidence in how, like you said, how do you deploy? But then on the other side of things, we know, or we've been taught that, joint restriction, soft tissue, all these things are important, maybe overconfident in our ability to have an effect on those, yet the understanding of why those things exist. Do they exist, which is kind of the crux of, more of this conversation. Yeah. And then deploying an overconfident strategy when you don't know the why, to me, it's not that it's unsafe by any means, but it still lacks, I just don't think we ask enough questions as clinicians. I think we silo ourselves off as, I'm a clinician, I need a researcher to tell me the evidence. And then, I think we have a spectrum of clinicians that, some are maybe not wanting to dive into the research that much, right? They kind of go based on what other people teach them and things. Nothing wrong with that. Nothing wrong with any point you land on the spectrum. Some that'll read and try to interpret on their own, and then some that I think read and get led too far off of the reservation, which leads us to why you and I are talking, that this conversation kind of got drummed back up, which, I love talking anyway, so I'm glad it did. But because of an interaction that I had on social media with just somebody that's maybe, in my opinion, right, too far off the reservation on the evidence side, that it's led to basically a siloing or a closed-mindedness. You could be the other side of the spectrum for, in presenting the exact same way. What I wanted to bring you on, or why I wanted to bring you on, is I think you did the best job while you were leading or at the head of the education for rock tape, of taking a lot of evidence that was out there, interpreting what it meant to you, and hopefully that interpretation wasn't, completely just a singular biased view of things, that a pretty open-minded approach, but not only take an interpretation, but then made it applicable and easy to deploy for all these other clinicians at Rock Tape, taught for the past, decade plus. So looking at all that information, the crossover of, your big, initial focus was the afferent input and, the sensory overlays between interoception, mechanoreception, proprioception, and now, like you said, your focus kind of shifted as things got more complex into more of this, organism matched with, how we approach these things. So how I'd like to dive into this, if you're game, and I don't know if you looked at the free form that I shared with you or able to kind of go through that. I think this would be a really interesting exercise for, I'm interested to see some of your thoughts on this stuff, of walking through the history of why we got to where we are in terms of what are we treating as, manual therapists, right? We could all say joint restrictions, range of motion, some sort of soft tissue aberrance, and then movement, right? And, whatever hierarchy you want to put those in, that's up to you. But if you're cool with that, I'd like to share my screen and we can walk through this together and just kind of have a conversation on that. And then that will lead us to where are we at today? And then obviously I would love you to weigh in on what do you, what's changed, over the past even 5 years since our last conversation, on how you would approach things you used to, do. But then also, like, where are we going? Like, what question should we be asking, right? What's still left on the table that's, giant gaping holes, or we just have lack of connections? But I think this will be an organic way to kind of just walk through that conversation. So if you're game, I'm going to go ahead and share this.
Yeah, that's quite often a visual seems to help kind of at least drive the conversation. So I'm looking forward to it.
And I think mostly clinicians, because I get pretty nerdy on these podcasts. So it's probably mostly clinicians. But let's say you're out there listening and so far you're like, Jesus. If you're not a clinician, I think this is important too, because if you're a lay person, patient, you're just interested in the health field, you're going to have to become more and more of an advocate for yourself. And not that you need to know maybe the nuance we go into, but if you listen and read at a level that's higher than what's going to fall back on in your everyday interactions with your physicians and what you're doing for your health, I think that's no different than, you went to school maybe for an undergraduate degree in marketing like I did. I don't use 70% of it, but I'm still glad I learned all of it. Like, that's kind of what I think we can use for the layperson here.
And if I could add to that, is that you get, just having that information allows you to ask better questions to the expert that you're interacting with. And this is part of the discussion, is that quite often it's the patient-doctor relationship, regardless of what type of medical professional you're talking about. The general, and if we're talking about historical reference, patients would have generally thought that we are being operated on by the medical professional. They are the experts, and they operate on us. And that model has changed pretty significantly as time's gone on to where now that therapeutic alliance, where the two are working in tandem. And to have an alliance, there needs to be input from both parties. So I think that's critically important, to be able to level up your understanding, not to be the medical expert, but to at least know what questions to ask, because you are the lived experience. So your component to the conversation is critically important for the clinician to make better informed decisions.
It is, I think this is wildly important, because I think people may think, oh, these guys are chiropractors. They're talking about, if hands-on, musculoskeletal. I think it's more important if, you're going to somebody that's possibly going to operate on you, because there's no going backwards from that intervention point. So the questions and the front-loaded knowledge that you would walk into, I think that's wildly important. In particular, when we see that there's I don't want to use myopic, but less tools at somebody's disposal, those tools are going to get used way more often. If you have more tools, you get to choose what you access based on the, the case in front of you, the organism in front of you. So, yeah, I couldn't agree with what Capo said more of, like, we are in 2025, and I think in the next 2 to 3 years, between the realm of insurance and the way the medical field is going in general, like, the individual, they already should be at the center of their healthcare for autonomy, responsibility, all of that, but it's going to become wildly more important. So as we go through this, we'll be having a combo, and if we started this historical look at this is in particular looking at around trigger points and nerve sensitization, but like we could go all the way back if we were trying to have some fun anthropological journey of, Otzi the Iceman and tattoos over supposed arthritic sites or pain relief. We don't know. But what we can say is historically for thousands of years, or at least, written record and sometimes archaeological records, we know that people have interfaced with each other through manual therapy of some form, acupuncture, massage, hands-on, bone setting, whatever you want to call it. It's happened forever. Something doesn't persist through time without some sort of valuable interaction actually, happening. So, if we skip ahead real quick and we say 2025, and now we have a whole sect of our profession that's saying, a hands-on approach is not only not valuable, it actually may be dangerous, right? Maybe making people, too adherent to the clinician and things. So I think that's where I want to create a conversation. Not that nothing about this is me presenting an argument. I'm right. This is the way. It's like, well, what are we missing that's led us to this point of where there's such a parting of the Red Sea of ideas, and the only person that really is at a detriment at the end of this conversation is the patient, because they're the one that has to interface with these clinicians.
That's right.
So we started in 1938. This couple guys, Sir Thomas Lewis and John Kellgren, found that saline injections into muscles led to pain referral. So before this, people talked about top bands all the way back in the 1500s, but this is the first time we were like, hey, there's this complex thing happening where these muscles that are sore or tight, that if we do something to them, that pain will show up other places, right? And forever we knew that, nerves cause pain and they can be, away from where the injury occurs. But that's the first time they're like, well, let's explore this a little bit further. Well, then, one of the most famous OGs of, trigger point, I guess, research and input, Janet Travell. So I didn't know, looking into this, that Janet Travell was a cardiologist. Her father was a physician, which I think brings a very interesting point into it, that the way that she was led into looking at trigger points in the musculoskeletal system was those were some of the main complaints of her cardiology patients. Right, that there were these, we know that there can be this sequela around a cardiac event of this left shoulder pain and jaw stuff, but people were complaining about other things, and she is a masterful clinician, so she was trying to put the pieces together. Do these things matter to my case? So that's where by 1942, she had written Pain and Disability of the Shoulder and Arm, Treatment by Intramuscular Infiltration with Procaine and Hydrochloride, which was based on the work of the two gentlemen we just mentioned. And then, I'm not going to go into depth on each one of these, but more and more articles start coming out, right? Looking at, hey, myofascial genesis of pain all the way back in 1952, right? And, we're going to congresses now looking at fascia. It's wildly misunderstood, or it's like looking out into space every day. I feel like there's some article of oh God, we're wrong. The universe is actually we're living in a black hole, or who knows. It's grand scale, much less maybe important things to the general populace, but that's what we're looking at here, is these things kind of been echoed through time. So Dr. Travell gets more and more notoriety within the medical profession in general, right? Cardiologist, moves into this musculoskeletal world, becomes a personal physician to JFK, and not just JFK, a couple other politicians, and kind of lives in that sector for quite a while. I bring that up because, again, you don't get into these seats just based on personality, just based on connections. I have a very good friend and colleague that I talked to this weekend, and I go, do you think your reputation got built on the dollar amount that you charge and the clientele you work with? And her very astute answer was, they wouldn't have paid for it if it didn't work. It's just, you can sell a Ferrari, but if the Ferrari doesn't perform like a Ferrari, that's not going to last that long. So,
great point.
And then we see, again, from basically 65 all the way, and I'm not going to go through each one of these, more and more people, different people, looking at what in the heck is going on, right? We know Janet Travell, and then, eventually Simons kind of joins her, looking at, we have these type bands, there's these referral patterns. We're also, an important note is here, the 1940s, we kind of hit this industrial revolution. We see assembly line workers and this repetitive strain injury hypothesis come around, which leads to some of the ideas that Janet Travell first proposed of this kind of sub-threshold muscle injury overuse, this muscle's just getting micro injury, more or less.
Mm-hmm.
And then we have other people, kind of just weighing in. Janet Travell and David Simons, 1983, first edition of myofascial pain and dysfunction. So these are tomes, I guess, in our world of, maybe the treatments in them we wouldn't hold as kind of the gold standard anymore, but the roadmaps of trigger points, the referral patterns, and what the kind of general idea of what's going on still holds water, but maybe we're now getting into the nuance of why are these things occurring, even though the roadmap of what's occurring hasn't changed a whole lot.
Let me add something to that, Doc, is that this was the central understanding and knowledge for the current day practitioners, and I say that because the professors that were in that stage of their career, probably in the student phase of their career, were learning from these textbooks and this type of information. How did that influence them moving forward from their clinical experience to their educational experience, and how that has distilled its way to you and I that are currently in practice now? So we have to understand the importance of this 1983 edition, of how it influenced two generations of manual movement and medical professionals. So it's critically important.
And one thing that I guess maybe this occurs in every field and every athletics and every era. Looking back, it looks like there were explosions of information that might be happening now, but we just can't look back in a retroverted fashion. But at the same time, that's something maybe in a future, if I gave a presentation like this that we should talk about, is like all of the other things that are happening in the world with all of these other clinicians around this time. I mean, this is also, prior to this is where you're seeing the work of Yonda and Vojta and people like those starting to come to the helm. We see, Maitland and, Syriacs, like all of this is happening within the, late 60s to kind of, to today, but like really ramping up around this 1985 to the late 80s. And information didn't travel as fast back then. It definitely didn't travel as fast via the research realm, right? PubMed wasn't sending people email crawlers.
Great point.
So when similar ideas come about, which is a phenomenon itself, that you see, an idea may occur in Australia and North America at the same time by two different people, and it's eerily similar. I think there were a lot of things happening that some things refuted one another, some things lined up. But like you said, this is coming out of the US, right? So I think, and this is going to sound like I'm detracting from what happened here, a lot of what happened in the US, physical therapy, chiropractic, PMR, musculoskeletal medicine side of things, was based on this, where then we think that everybody else was maybe ahead of the curve coming from Eastern Europe and Australia. It was just different. Mm-hmm. Right. So like we see all this and everybody's like, oh yeah, that's wrong. I'm a McKinsey guy, I'm a Syriacs guy. And it's like, well, it was just different. And anything that's different or novel or exotic sometimes just has an allure to it. And because again, it doesn't say that this is wrong. There's a million different patients that are going to present a million different ways. And that's why there's a lot of different tools. And it's, the crux of this conversation will end up at myofascial pain syndrome of like, is that a thing? Because that's where fascia gets wrapped up into this. And is that the major component, a component, what's going on? But we'll get there. 1988, we start to see now people are, well, prior to this, I should back up and throw it in here at some point. 1977 was the first time that we'll throw the author's name in because I'll put all these articles in, but where the overlay or the overlap of acupuncture points and trigger points first occurred or was looked at. The initial research into that saw about a 77% overlap, and then follow-up research went all the way up to 91% overlap. Why I think that's important, which I'd love to hear you talk about this, and Anthony Stecco actually has a class on this, 8-part series for trigger points and Stecco points. Nobody to this day understands how acupuncture works. And if we wanted to say that modality doesn't work, there's a reason that the VA relies on that heavily for pain relief with their populace.
Right.
So when we see this massive overlay, again, it's a modern day attempt to explain something that's worked for eons, and then we're just like, well, the best we got is there's this overlay of these trigger points, and it's not exact, but it's really close because the referral patterns looked at the meridians and the points looked at trigger points. And I'm just like, okay, ideas are they're fusing together, and maybe we're getting closer to the answer if there is the answer. Any thoughts on that?
Yeah, I'd love to add just to our preliminary conversation of what I got to experience at Fix, listening to Dr. Stecco, Antonio Stecco communicate the model, and listening to him for over the last 8 to 10 years. You think about where that information was distilled down to him from his father Luigi, and how that information has been presented for the last 30 years within that family itself. And so taking what we knew from historical reference, looking at these meridians as an example, and how as information is provided in a systematic way, what the Stecco family has integrated into our understanding now is how we're now overlaying this quote unquote new tissue, this tissue that we're better understanding because of new technology, advancements in dissections, advancements in imaging, that now we can actually better understand this layer of tissue. And when we're talking about controversy, I still can't believe how much dissension there is between the manual therapists of accepting fascia as a medium that we should at least understand, and others that think that it's complete lunacy. But listening to the evidence coming from Stecco of talking about this layer of tissue that overlays and encompasses all other tissues, and now starting to make those relationships between meridians and these fascial connections, which the Stecco would call centers of fusion. It's just so fascinating to me as a learner to start to get the aha moment saying, gosh, experientially, as a therapist, when I put my hands on these specific sites, call them meridian points or call them centers of fusion, it doesn't really matter to me, but the outcomes that I've been able to see are substantial. So we can't disregard that. And nor am I saying that I know the answer, but at least we're getting closer and closer to better understanding what these tissues are, how they influence our experience, pain and movement. And I'm just being a curious learner. And this is what I hope everyone in this space would preferentially lean into information as a curious observer. Obviously, understanding what's within your scope, but the curiosity is the first lever that I would want people to actually start to at least lean into, because you get the opportunity to actually listen, and then you can start to distill the information accordingly. But Stecco has really provided me, going back to our term on the roadmap, that this network of tissue that we've disregarded for 500 years now might have a greater relationship with something that we've called meridians, and we can now better understand what these meridians are and how they influence the patients that we interact with. So I know that was long-winded, but it's really important to, one, collect the information with a curious mindset, then do your due diligence to be able to ensure the information is sound and science informed. And then we get to do what manual therapists do, which is why they call it a practice, is actually practice it, to be able to identify what changes we can see with the peoples that we serve. So I think it's critically important to take all of the information from everything that you've presented historically and now start to layer what we can do with the current technologies and techniques that we have available to us.
Yeah, don't worry about being long-winded. That's the whole idea of a podcast, right?
Right.
But one thing because I do want to talk about this now. I know this is kind of, a little diversion. We talked about how kind of there's this divide that, maybe one half wants to throw fascia in the trash can, just like, we did with dissection forever. And then, I wouldn't say it's the other half's like, oh, it's the most important, but like it plays a part. And yeah, maybe I think where things get interpreted as, there's this big swath of, what we're going to call it, the majorly evidence-based group, which is such a funny thing that's the people that maybe we call off the radar now, which is wild. But I think it's two things. I think the generation before me has lived in a medical system that's not been awesome. So when you live in a system that's broken, you kind of want to push back wherever you're at, even if you're a part of it, right? As a clinician or, a trainer or whatever. I think there's that. And then I also think that there isn't a lot of information that can connect the dots really well. It presents things in isolation, right? And that's the way the research goes, right? We know things, right? We know about fluid matrices and how that affects fascia, and maybe there's fascial communication that's operating in a different way than the nervous system has previously been described. Like, and I think when you get that stuff and you have a hard time with the gray areas, the default for some people is just shut it down. And if for the other side that's maybe trying to integrate or practice things based on things that are actually out there, not made up, not just, some far-flung idea, that just kind of is like, oh my gosh, what a silly notion to try to do that. That's not right. Nobody that was an innovator ever or never did anything that wasn't kind of a little silly or laughed at. If they wouldn't have, they wouldn't have got to where they are. So if in 1970s, if somebody would have told Bill Gates that like you're gonna have all of this stuff operated out of a box with a keyboard as an interface, like they're like, what are you talking about? Like that's not gonna happen. Like computers take the whole room now. Now we're talking on a computer like that's the size of a book.
Right.
So if you're gonna make innovation, you got to be willing to go. Now you could just go outside the realm of like, what we do know and make up your own stuff. Yeah, that's not being evidence based in the least. And I would agree that those individuals maybe need a little more help. And I think that's why we do things like this and teach people and have podcasts, because like I said, not everybody likes to read research, nor, maybe they won't. But that's where there has to be other ways to learn and people that are willing to kind of connect the dots. And, maybe there needs to be a new term for people. Maybe it is just a clinician or practitioner, but like people that are wildly curious and want to read the evidence as it exists largely and then try to put it in practice, not just researchers and then clinicians, right? And I know we're supposed to do that, but our profession in particular is really poor at that. You get into the, uber specialized allopathic, it's a little bit easier because we can take these thousands of articles that are being pumped out every week and say, well, I'm a neurologist that treats, brain aneurysms in particular in the posterior sector. And you're like, that's a lot easier to get like your research taken care of and then put it into practice. And you're probably also involved in the research, not only practicing at that point.
Exactly true. And also think about the complexity of the issues that we generally are faced with as it relates to manual or movement therapists. It's not as specific to an infarct to a specific region of the brain that we can tease out very specifically. When we're talking about pain, we're talking about a complex system, and that's part of the discussion which I hope we get into today is, regardless of what we want to identify, a trigger point, myofascial pain, chronic persistent pain, it's an experience, and how we interact with that experience is specific to the individual that you're working with. So I think when it comes to the evidence-based practitioners that specifically lean on, and I have colleagues and friends that are inundated when they say something on social that might be quote unquote controversial, and then the evidence-based, and he calls them trolls, come out and say, tell me what paper you're pulling from. And he throws his hands up in the air and quite often says, my gosh, if you're looking for a specific paper, you're not going to be able to find that. But that is consistent when it comes to myofascial pain syndromes in general. So why I generally say curiosity with a backpack of science information is critically important, because we now have to accept that we're working with this complex system and we lean into the evidence, but we're not shackled by it. And I stole that specifically from a good friend of mine, Paul Coker, a physiotherapist from England. And he said that to me for years. He goes, Capo, we need to be informed by science, but we can't be shackled by it either.
Yeah. And I try to remember that, because I'll even get a bit, like we all do, we have our biases, right, that we lean into, and I think you have to be constantly questioning those. That can be a detriment, right? Where you question too much and nothing works. But like, yeah, the questioning, that's what's fun for me. Like, I love treating patients in the puzzle, but
Yes.
the what are we doing and why is it working and how could I do it better? That's what I'm very interested in, which does give a better patient experience in the end, right? But like I was with Brett Winchester this week, and that guy loves treating people because he's a masterful clinician, but like each person he's like sharpening his own sword.
Right.
He is he is that, whatever that name is, a practitioner of well versed in the information out there, putting it into practice, not afraid to go into the gray, but leaning heavily on well-founded things that we know that are going to work, are always, I wouldn't say always safe, right? But very, very safe because they're evidence-based, right? We're not going off the radar of like, oh, I have an opportunity to maybe hurt somebody or do something that's, not within my scope. All right, let's keep walking.
Yeah, please.
So we went into the 1988 article. So 1994, this is where stuff starts to get, it's funny in our world. It's like, ooh, a contentious debate. People outside of our world are like, oh my God, this is the most boring thing I've ever heard. But around this time is when all of these kind of some very smart people, I think of John Quintner, rheumatologist who's now retired, still out there kind of publishing some stuff, started kind of questioning. He was one of the first ones that started kind of questioning, like, are the proposed mechanisms, in particular, his attack was on myofascial pain syndrome, which Travell Simons and some others had started talking about. Trigger points are at the center of this myofascial pain syndrome. There were then theories of why trigger points existed, and then theories of how those trigger points affected global pain. He pushed back, coming from a rheumatological background, which I think is a cool background to have pushback because you're looking at immune-mediated responses to pain and what's going on with the nerve and the nevi novorum. So different theories started coming about. Mm-hmm. And then for the next couple years, these were pretty quick, you started seeing different articles come out that looked at what's going on, like why do trigger points exist? Because like you said, when schools started teaching based on the work of Travell and Simons, now you're teaching based on a theory, which a lot of things are theory. But when that theory doesn't, I agree, if that theory doesn't get explored enough, you're not asking questions. You stop being curious about a thing. If we've learned anything about the Alzheimer's talk, it's that when flawed research or data is the center point of all other research, and then that ends up being flawed for whatever reason, that really messes stuff up. So, it can be a tripwire, but that's why this kept getting looked at. And that's what I'm trying to highlight here is people didn't just say, oh yeah, trigger points are a thing. People said, are they a thing? Why do they happen? What's that mean? That's the whole question on the trigger point, which leads us into all these other realms of nerve sensitization, pain, and what do we do with all this? So again, around 2004, we see this an expansion on Simon's integrated hypothesis. And again, I'm going to be putting links to all these in the show notes. So anybody that hasn't seen these or you want to read the full papers, there's links to these. But the expansion here now became, okay, maybe it's not this sub-threshold injury thing. Maybe something's going on with the nerves or the vessels around these muscles, and we don't know if it's feed forward or kind of a feed backwards, right? Like, are they getting irritated first, or does the muscle kind of have something going on? Nobody knew. But what started to get brought up here was, well, now we know that there's something happening centrally, right? The spinal cord mechanism started getting looked at, that we saw, hey, your dorsal column's kind of getting pinged with some data. Central sensitization was just starting to be talked about more and more. And we now know that, well, maybe that's, again, chicken or egg. Nobody knew and maybe still doesn't know which one started first. Mm-hmm. Is this peripheral manifestation of pain and tight muscles or tone change and referral, is that associated with what's happened at the spinal cord, or did that start in the periphery? And that's still, I think, an unanswered question. I don't know. But then a couple rebuttals went around. And that's where, as we got out into 2014, the trigger point, whatever you want to call it, it's like a social media battle happened, right? Where we saw Quintner and Beau kind of going up against some of these other fellows and going back and forth, which is hilarious because this is the fastest I've ever seen research come out where one paper would refute the other paper. It got published, and it all happened within a 2-year span, 2014 to 15. And then Jay Shaw in there, which Jay Shaw had research before starting in 2005, talking about this, but kind of came out and was like, Well, let's just look at the whole thing. And that's what Capo and I talked about on the last show. We went into that article in depth and said, well, what do we understand about, what that article said in 2015, how much had changed, at that point in 2023. And that's kind of where I want to, again, I'm looking at all these critical evaluation and Quintner. They just kept going back and forth. And the funniest thing is all of them say the same thing, right? They're refuting the why, but the what, that whatever we want to call it, right? We could call it Voldemort. We're not going to say the name of the trigger point exists. The phenomena exists. Uh-huh. The question at the end of everybody's paper is, what do we do with it? The mechanism of why it's happening, which you have to question, is all they're debating. But that's been interpreted, extrapolated as they don't exist, they're nonsense, they don't matter for treatment. Any paper you read from 1952 to now says the phenomenon exists and we don't know what to do with it. That's basically what it sums up, which is like hits on your point so hard of like, if we left it at that and people are starting to say it doesn't matter or that's all I treat, we're still missing the point. And we need clinicians and researchers to question that and say, I mean, what if a clinician like Brett Winchester has 60,000 at-bats, right? I don't know how many he's going to have in his profession. And he's paying attention to stuff, and then he's involved with the school and can kind of say, well, I've kind of seen this. That's how a hypothesis forms. That's how you have a studyable thing for, a research article. So we'll move forward a little bit in time here. Now, as we get past 2015, we start to see, we're seeing more musculoskeletal pain globally. It gets looked at in different ways. We start to see, is this myofascial pain syndrome thing real? Fibromyalgia is getting talked about more. What's going on with this musculoskeletal burden that's seeming to become a tidal wave that's going to hit in, the 2020s? And as we look at that, more and more people get involved in the debate. Right. Obviously, we have, if we want to call, the pain specialists, in particular out of Australia, like Mosley and those people. But we see more people out of neurology and rheumatology and infectious disease actually get involved in the conversation with all of these could-bes. Hey, like this could be causing this. Mm-hmm. That's where when you can take connections out of different professions. This is like across, not the medical field. This is all fields. One of my favorite books ever by Epstein called Range talks about this. This is that people that can cross over into other fields are the ones that are going to create innovative changes in the world. Same thing here. If we just stayed, if like only neurologists or only chiropractors or only rheumatologists looked at an issue, you're going to keep coming back with relatively the same answers unless you just get a maverick of a person in there. It's when those people look at other people's research and then other people study issues outside of their field that things tend to change. And one of those articles actually is this one from 2020. So the criteria used for the diagnosis of myofascial trigger points, because all they were asking was, everybody keeps talking about these damn things and nobody, top bands, predictable referral pattern, can be palpated. And then they said, well, what would a clinician actually use? And it came back to the exact same thing that Travell found, right? And this is not within our world, PT, anybody looking at that, said, it hasn't really changed much. And those referral patterns do exist, right? Because it's not just saline. It's if you push on these points or palpate, And then what got questioned in this was more of we'll do these latent and satellite trigger points. Is that a real thing? Like, can we tie those into a phenomenon that's all connected? Or, is that a musculoskeletal thing? Or is that a centrally, like now we're looking like central neurologic, which is where I wanted to take a pause point and ask a question to you. Something that gets thrown around in our field all the time is this quote by Pavel Kolaj, or it was popularized, whether he said it or not, that the trigger point doesn't exist in the muscle, it exists in your brain. All right. I would assume I know what that means. I probably don't, because I'm not in the mind of Pavel Kolaj. But to you, what would be your interpretation of what he meant? Because again, that seems like a very just at face value comment. And do you think, or what's your interpretation of that first?
Yeah, let's start there. I think there was a couple things that you said that I want to, without going back in respect to what we've been finding for the last 10 years. So the 2014-15 is a critical point. As you've already highlighted, in respect to what the literature and then the subsequent rebuttals have been. And to echo what you just said, if you dive into the literature, and I have my own reports, and I'm even referencing some here, it's just some of the quotes that came up were just reminds me of the stance that I held true and hold true now, that curiosity matters, is that they kept on saying the same thing, that dismissal stifles research. Personal attacks doesn't get us anywhere of just personally attacking the individual conducting the science, or an individual that practices in a specific way. None of that is going to get us anywhere. So dismissal, personal attacks, the things that we generally see that gets more clicks on social media is not moving the needle in a favorable direction for any of us. So let's start with just agreeing the fact that we may not have all the answers. Those that believe that touch versus no touch is superior, the opportunity exists now because we have enough information to now come together and then come to a consensus. But today I don't think we're going to solve that problem, but I wanted to start with that. As it relates to, and I would agree that I'm not sure if the quote is coming directly from Kolash, but we know that sector of therapists and that network of therapists around that time, we're starting to understand this idea that we're actually excluding the brain's involvement in our experience. And so when he says that, or they say that a trigger point is more centrally mediated, how I interpret that is that the experience is different. Now, there's some consistencies in the referral pattern, as you referred to, but tell me the last time, and you've been in practice not as long as I have, but we could both kind of put our time together and say we got a good 20 to 30 years of experience, and I don't see the textbook distribution of a trigger point at the mid-trap area consistently for every individual. But there is some type of referral pattern that I generally see. My point on this is that central is the person's expectation, their threat, what they interpret that pain site to be could potentially increase the distribution of that or decrease it. So it's the brain making that assessment, not the tissue. And we've been conditioned, and I've been conditioned, I'll speak for myself, with Travell and Simons and all the information that we've gathered to say it's in the muscle. I know that it's a taut band, so I can put my myopic brain and really kind of come to a picture of what that looks like, and I'm going to smash that nodule out, and I'm going to improve the symptoms. It didn't always work, so I started asking more and more questions, why is that? And it always came back to the individual presents the experience, not the tissue. And so I actually lean heavily towards that model of thinking that all of these experiences are centrally mediated. So we should at least start that conversation now, so then we could be more specific in our dosage and all the things that we've talked about earlier.
And then again, this is the whole reason we're on this podcast. We dive as deep as we want here. When all these theories, because there's a Cinderella hypothesis, a subthreshold injury hypothesis. There's 5 or 6 that have kind of persisted, and it's the integrated, whatever we want to call it now, integrated hypothesis of myofascial pain syndrome. One of the central themes, again, that is not debated whatsoever is that, hey, there's something happening in the muscle. We don't know how that starts, but once that kind of kicks up, we know that there are spinal cord changes, right? And at the spinal cord, this is one of the most interesting, which is just a theory, is that information's coming into the spinal cord, and then we know that, via the dorsal column, the spinothalamic tract, that, you have multiple levels of kind of neurologic play, that might be these weird referrals, right? That you can push on your glute med, and you might get a spot in your soleus that lights up, and it's it's just a relay system problem. Mm-hmm. I would agree with you, because this is also in the literature in these exact articles of the more spinal cord changes we have, then we see, almost instantaneously, we see S1 cortical changes with, some of these, injuries or whatever's happening in the periphery. Yeah. That is, the limbic system's getting its bell rung. You could have a more diffuse response, a wildly different one than we've ever seen, right? It may be persistent without palpation, right? That's where we're seeing the trigger point that is the pain referral that, is being caused all the time. But I think, it's this this complex organism that, I guess what's always keeping me up at night is the tripwire. What started this damn thing, right? Like, because that leads us back to what are we doing for intervention? If this is a completely centrally mediated phenomena, I don't know how big of a job I have with somebody in that room. So I don't think that's true.
Let's dive into that, because this what gets me going, because this is where the manual therapy, those that argue that manual therapy is overutilized, it leads to reliance, all the things that you brought up earlier. And I would argue is that we need to first accept the fact that patients or clients that seek care, they have certain expectations. So just quickly, removing that expectation and saying, well, I don't do that here. What does that do to the patient doctor, therapeutic alliance, when the expectation is that I do expect, I've had personal experience that touch gave me relief, and I'm leaning on your expertise, the expectation is there. So at the very least, understanding where the person's coming from and knowing that you've been trained as a manual therapist to put hands on or using instruments, that should still be on the table. Now, if you use it or not depends on multiple other factors. So let's start with, I like to integrate manual, or let me get away from even using the term manual therapy, because quite often people have certain interpretations of what that means. Let's just use touch. I'm going to use touch as a way of communicating, and I've been saying this for easily 15 years, that touch is a conversation with the brain. So if we can, at least I accept the idea that our experience is mediated by our brain. The brain gives us pain. It's what provides us the pain experience, not the nociceptors and the tissue. Those are just signals to the brain, just like touch is. So I would argue that touch is a neurological conversation that we should be leveraging. How much we use, how we combine that to other therapies that give body ownership, which I'd love to talk to you about, to the individual. I would argue that, yes, we need to move towards giving someone the autonomy to control their own body and their own experience. But if their expectation is that they expect hands-on therapy, that we do have evidence, Stecco and others, telling us that these therapeutic interventions do influence the tissue at a local level, but we also have evidence to indicate how it communicates to the brain, especially if you do it with specific intent. I struggle with the idea that we should be taking something off the table that has historical, relevance and salience to the individual, and don't have the ability to marry it back to what the new evidence is telling us, that yes, the brain is the central governor, but we can actually influence the brain from the outside in. I don't know why that's a problem.
There's a lot to talk about here. So I say we just take our time, but I think something that is a tone in there, when we throw the baby out with the bathwater, for whatever reason, you're literally not a clinician anymore, right? So if you said, hey, the Steccos are saying that there are, things that can occur in the soft tissue matrix, whatever, we just want to be broad,
I think that's good.
That require intervention. Like if you have densification, what are we going to call it? Densification, adhesion, even those words now, oh my God, we're creating, some sort of effect on somebody's limbic system with that word. Mm-hmm. But when you have that, there are things, in my opinion, that will not be changed by working in a centrally mediated fashion. There are things that are purely centrally mediated. And then there are most things that live somewhere on the spectrum. And that is your first job as a clinician, is to figure that shit out. And that's what probably drives me nuts the most, is that when we say, well, that doesn't work, or these don't exist, or we can be completely hands off, you are no longer a clinician, regardless of what you say you're doing or treating or not. Because being a diagnostician, right, and whatever value, that could be a personal trainer, right? Diagnosing, like, I shouldn't be training you because this seems like you should be elsewhere. So put on your thinking hat and be a humanitarian and have empathy first of like, okay, what should I be doing based on all of the information? And then there becomes hierarchies with what should be done first, or the best approach for the person. And that's, in my opinion, where the complexity comes in, is we could have 50 tools. We know that there's pathoanatomical diagnosis, centrally mediated phenomena, chronic pain. You don't only have to pick the right lever. You have to there is an order of operations that's going to, in my opinion, provide the best results efficiently and effectively for a patient. Yeah, I don't know if I have a good, volley back to you, but I think we just missed the diagnostician part. And I honestly think that I was kind of part of that when I was part of the organization. Is great, but R2P, I saw that there was this jump to, well, we can just be hands off and movement first.
Mm-hmm.
Well, sometimes, yeah, for sure.
Right. So you did volley that, and you might have even spiked it down. And I need to kind of at least present where I think a good starting point would be. I completely agree with you. Clinicians, the requirement is to collect data on the individual that you're working with to be able to make an informed decision. And social media is unfortunately muddying the water because they're putting blanket statements saying manual therapy is just being ignorant, and if you use it without information, I might argue that you are being ignorant and you're just kind of throwing the hammer to any nail. So I'm going to start off with, and I've been saying this a lot lately, and I actually had a great conversation. We can actually have a conversation about it because he's actually provided me. We're going to be doing a collective webinar as Dr. Lee Burton with FMS. I know you're familiar with them. Familiar with the organization of FMS, the Functional Movement Systems. And one thing that, and I swear I'm going to pull this back into gathering data, because the more information that we have, we can make a better decision on what should be doing with that individual. Is it a touch intervention? Maybe not for someone that has a previous experience, a negative experience, might even have some ACEs, like previous childhood experiences, that we shouldn't be putting hands on that individual. But if you don't ask the right questions, don't do the right questionnaires that are objective and have been validated to be so, we're not leveraging those at the rate that I think we should. Are we taking advantage of technology to be able to capture information on movement from a local movement segment to global movement? Are we gathering the information, right? So I think that's critically important as a clinician to decide, should touch be used or not? Should it be movement focused? Those are all decisions that would be based off of information. So just putting out a blanket statement that no one should be touched, I think, is ridiculous. And the evidence is indicating that touch can influence both pain and movement. So we should be at least diving deeper to get better idea of why that is. Stecco and others in this category are doing the research right now. He shared with me in Malaysia that they have well over 200 papers specifically on the technique that they've created. So it's not like they're making this stuff up, which frustrates me to hear those that are competing with the knowledge that they've provided with a social media post. It's just ridiculous to me. So let's start with that. Get the information on the individual that you have to make the informed decision. Now, I would like to volley back to you to say, okay, should it be a touch modality? Should it be movement? Is it a combination of two? And why do we think that? I think you and I both are on that platform that it's a combination. It's not anything in isolation.
Yeah, I'm reading The Explorer's Gene. It's Alex Hutchinson's new book, and always been a fan of his, and I would like to think that I'm some sort of Christopher Columbus, but not a professional. I don't think that's true, but that's what I'm going to say. So I'm on some exploration. We'll find out what I'm looking for. But I bring that up because in there he kind of has this idea that if we can say again, I'm willing to change my mind. That is one of the hardest things to do, and people can be too willy-nilly, right? And that means that you don't really have a basis upon which your thought process is actually working, right? You're probably just being led by the prevailing winds. Or obviously you can be too rigid. I find myself being so curious of what is happening. I feel like I'm very open to changing what I do. right? I've told students forever when I teach them, like when I first learned SFMA, it was painful for my patients because I took everybody, existing patients, new patients, through a full SFMA, which I was terrible at. So I was just curious of like, is this as important as Greg Gross thinks it is? What would I find out that I'm missing? Like, terrible experience for them, but I learned a lot. I've had to kind of, the further you go into practice, I think using a methodological approach, and what I mean by that is like you find information, you supply an intervention to somebody, whatever that intervention is, and then you get the data back, which is a huge key. And then you have to start making decisions eventually that aren't based on the things that you were taught by somebody else. Right. And that's even people that wrote textbooks or that were researchers. You have to kind of start saying, well, I do agree with that notion that is, something I learned from a physiology book, or I disagree with that notion of somebody that I heard at a seminar, right, that I've been doing forever. So to answer your question, my thing is, yeah, it's always a combination. I don't think, obviously everything lives on a spectrum, but I practice a certain way, you practice a certain way, because we've picked the things that probably are meaningful to us with experiences we've had, right? Things that have worked with us in the past, then you are biased by that. But what I try to do is say, why is the thing happening to them that I think I need to treat? Because what I'm not treating in people, and I would like to know what you would like to say about this, but I'm not treating pain. I want them to be out of pain, but I can't treat an experience. I can't. I'm not somebody's conscious. I can't do that. So if I can't treat an experience, I have to say, why is this thing happening, right? Is it a belief that they build? Is it a movement aberration? Is it all of the things that maybe, people are like, oh, you can't have aberrant mechanics, all mechanics are good, trigger points don't exist. They're all possibilities to me, right? And my job now is to take all the data I've had throughout my, my life, my learning, and then my career and say, nobody knows anything. They're physiological laws, like even Wolff's law could be wrong. It's stated as a law. Laws are broken all the time in science. So now my job is to not take anything at face value, question everything, but you can't be so questioned or so in the gray that you don't have an action piece. And I think that's where a lot of the social media people that live on the, they don't have an actual piece to even go on. They wouldn't have a basis to say, well, this is what I'm going to do, so everything is bad or negligent or whatever. And I think the best in the world are the most open-minded, which is an impossibility to be like, a baby. You're having an experience. You've had all these experiences. My 5-year-old daughter, she hasn't experienced something. So her mind is open, or as open as it can be, and then it's slowly either closing or hopefully staying as open as it is, or maybe opening more. Yeah, a little bit of a tangent, but I think that's how I approach things is tons of tools. It's always a combination, but I could be very, very, very wrong about something. Or I could be very, very right, and I'm just trying to figure that out.
So this goes back to what we just said. First and foremost, talking about laws and things that we thought were unbreakable can be. Wayne Gretzky's, goal record held for, over 20 plus years now, probably 25.
I knew you'd have to bring up hockey at some point.
I had to because it just got broken yesterday. Yeah. And my mind was conditioned to believe that would never be broken because it's the great one. How we identify things, just like and I'm going to, parlay this back to trigger points, how we identified it, we just get so conditioned from the repetition of that conversation to believe that it's a known entity. And so that record got broken just yesterday. And I watched it because I wanted to see it in real time to break the notion that any information, any record, any law can be influenced with better information. And we're in such a cool time. I get so excited about the time that we're in respect to the amount of information that we have available to us. We can take AI as a good example of how we can collect all that information and condense it to be able to make it usable. We're in an amazing time. So it goes back to my curiosity, conversation that we have to be curious. And just going back to what you asked the question, do I believe that I'm treating pain? And I would echo what you said. I'm not treating pain. I'm treating what motivated that individual to come in to see me. And pain is just one component of that, meaning that pain limits them from moving in a meaningful way. The meaningful way, the meaningful movement is what is motivating that individual. I want to focus on that. So the movement folks out there that say, well, why are you putting your hands on people? Because the hands-on is the expectation that that individual is coming to me with. They've explained that to me. And so I'm leveraging what's available within my toolkit to be able to get them to start to move, in a meaningful way again. That might be reducing their pain or their relationship with pain. So don't forget that it's not about pain obliteration. I wish that was the case, but the World Health Organization is only telling us that the experience of pain is only going up. All of the amazing technology, including movement, pain education, has all been around, and our pain experience is only getting worse. So I'm putting on my curious cap and saying, gosh, am I missing something with the individual? I'm not even concerned about the thousands of subjects in X study. I'm thinking about the individual in front of me, the information that I have, and if touch is on the table, I'm going to take advantage of it. But don't misinterpret what I'm telling you here. I'm not just beating the tissue like I did when I first got out, which was, Steve, you're a bigger dude. The last practitioner couldn't get at my psoas, and I know that this trigger point is in my psoas, so you better drop an elbow into that. I don't think that way because information has guided me to be able to better understand dosages. So I'm more informed in my manual therapy approaches, and I'm still leaning towards what my North Star is, as well as the individual that I'm working with, is that they want to move in a meaningful way again. So yes, I don't treat pain, but I do consider pain being a significant set of information because we do know that pain is a request for change. And so we need to take that as information from the individual to decide what we should and shouldn't be doing with that person.
Yeah, so let's dive into two things. So you brought up, there's this, whatever you want to call it. I mean, my book came out a couple, 2020 or so. And that's, at that time, the expectation by 2030, which it already is, it eats up most of the medical expenses, or matches the main, pathologies around cardiology, lung cancer, things like that. Mainly because of workplace stuff. There's a lot of musculoskeletal burden around the workplace that's getting reported out. But this is the thing that costs the most money in the world, right? And the pain experience is going up, and then we have to, obviously there's some sort of impossible delineation of, well, is it just pain? Is it actually a musculoskeletal pathway anatomical thing? That's a big task. Mm-hmm. What I get at is I think that some of this trickle down into social media and the practitioners' philosophical changes around manual therapy comes from this global burden, and then matching appropriately or inappropriately that, well, there's a rise in global, obesity, which I talked about these big three. General change in the amount of movement we have, both from, like you said, well, three things: meaningful movement, something that we do because we either need to or want to. Mm-hmm. Exercise could be separate, could be part of that, and then work, right? If you're a manual laborer, you move for your job or whatever, and then just throughout the day, moving less. So I think there's been a smashing together of more pain, right? Less movement, more obesity, and then a lot of logical people would be like, we just need people to exercise more.
Of course.
Not saying that's wrong, but I think when you take that, and like you said, you don't look at the person in front of you and you say, well, I have this approach because this is the overarching theme. Depending on whatever patients are coming to your office based on your referral source, your patient subpopulation, you might miss every one of those. You're absolutely striking out because of the global epidemic, and let alone that we don't even really know what's causing that. So you still got to, like you said, put your kind of curiosity cap back on. But I think that's a big part of where this is coming from, that we do see something going on. I think of Kelly Starrett talking about this, and Craig Liebenson, that kind of the approach is we need to get people moving. I don't think either one of them, I think that's a wrong interpretation to think that either one of them is hands off. No. They're taking a bigger swing, maybe because they have a bigger platform, right? And I think that's a big part of that.
Yeah. If I can add to that, there's, again, this conversation, as we've already noticed from part one, now moving into part two, that's going to probably mushroom into more, because you can't, it's difficult to put this in a box. And I think it's important, and this is part of the lack of communication on, and I hate going back to social media. It's not the only medium of information. So I wish we just would have a face-to-face, and I've told you this time and time again, maybe it's a virtual face-to-face, but I think opportunities like this allow for more calm discussions to be able to kind of weed through, the issue. And so because of it being such a complex phenomenon, if we're going to just go all the way back to trigger point, that it is a phenomenon, it's complex because we generally don't necessarily know what it is still to this day. We have much more clarity, and there are certain camps that would tell you that they know, but I still think we're still gathering the information. So leaning on that we have an idea, we do know that it's a known phenomenon, that people experience it. I feel it in my own body. Everyone has a sense of what a trigger point may or may not be. And so just having that as a starting point is a great way to start your relationship with your patient or client, if we're talking to clinicians, or vice versa, if there are patients or clients or just general folks that are watching this. What is your role in the exercise? Which is what I started off with, just having enough information so you get to ask better questions, and you can actually provide better answers as well when you know more. So I think that is a good starting point. It's just a recognition that both team members have an influence into what's going to occur. And then it's I think the term that I've read before is a shared decision making, SDM. So shared decision making is, to me, the evolution of what therapy should look like. Meaning, I have a toolkit, I have my hands, I have this instrument, I have these cool toys from percussion therapy, all the things that you see now. What's the biggest one that I saw at the last several shows? Shockwave therapy. Yes. So lots of cool things that we have available. And now we also have the individual. So as I was trained, I would know that I had a plantar fascia, scenario. I got enough information. I'm good. Get on the table, and I'm going to operate on you. And that's what I meant by operate when I started this discussion. Now, this shared decision making is like, here's what we do know, here's what we don't know. Let's be very honest and transparent. And the patient will say, well, gosh, that resonates with my belief system, my expectation of what I expect to be effective for me. And we come up with a plan that might include hands-on, it may or may not. It's definitely going to include movement, because if we both agree that we want to get back to a certain type of activity, that might be their job, playing with their kids, playing a sport that is meaningful to them, that fills their psychosocial bucket. Now I have a template to work from. And so, yes, I'd like to talk a little bit about what we're learning as it relates to, if I'm going to use hands-on, what should be my target? How do I know that? What is the dosage that I'm going to be doing, and how do I start to now provide information? This is pain neuroscience 101, to give the patient or client that I'm working with the ownership of how they could replicate this on their own eventually. Now, because again, it keeps coming back to the same thing. I'm so tired of the conversation, is that, oh, you manual therapists are you're setting the stage for reliance. And I go, yeah, maybe it was the case a decade ago, but the new docs, and I had the great fortunate ability to work even with some of your students with R2P, is like the new docs that are coming out are very aware of what their role is, and we're ready now to actually deliver an environment that's going to be so much more favorable than my colleagues coming out in practice in 2000. So I think we're in a great position, but shared decision making, taking the information that we both can gather to be able to make an informed decision on what the treatment should look like, with the ultimate goal of getting someone to move in a meaningful way again. That to me is the ingredients to the best experience, regardless of what therapy you're going to be using.
So let's try to get actionable, but clinicians first, just because I think that's, this, like I said, it goes round and round. There's no end, right? We can go to the end of the data, like, an article that came out today.
Mm-hmm.
it's not going to answer a question, right? It might get us closer to an answer. So if we're like, hey, we know these phenomena exist, right? And it's a system, or it's a system within systems phenomena, right?
Yeah.
Like we said, there's nerve sensitization that's occurring in the periphery and centrally. There's something happening in the tissue matrix. There's something happening both at the subcortical level and the cortical level. And all these things are playing together, and nobody really knows the tripwire. So knowing all that, my first question to you is, because I think this will help us then kind of like zoom in, why do you have an overarching theory? Is it just a complex, there's multiple answers? Or, why are we seeing so much more pain in the world, musculoskeletal burden, pain, with all of these, clinical tools at our hands, more information, more research, more textbooks, more iterations, more clinicians looking at it for the past, hundreds of years? Why do you have, I don't think it's one answer, but do you have any like bigger swathing answers? Like, this actually does help us if we think about it like this.
I have, I guess, opinion based on some of the literature that has supported this opinion, but also recognizing that I don't necessarily have the answer. And so the opinion that I'm kind of probably leaning more towards is that the complex, experience of a local tissue disruption, I'm going to use that as kind of like a broad term, that could start the information pathways that we know about. So let's say there's a repetitive position or repetitive movement that is leading to a burden of strain or stress to a local area of the body. So we all know of these. We can talk about tendinopathies. We could talk about strain to the musculoskeletal or the muscle itself. We could talk about how this interacts with the fascial system. Let's take the tissue off, but there's a local effect, and then there's the systemic or global, response, if I could use that. So I'm not arguing that there's not a tissue, at a tissue level, a negative sequela of stimuli that could lead to that danger signal being sent to the brain. So when we feel pain, I could call it a trigger point. I still call it a trigger point because I think it's just an easy way to communicate with someone, because we've been using the term for quite some time. I might take the opportunity to educate that it may not be in the muscle as we were once told. It may be in the local tissues, which involves multiple different connective tissues. So I get the opportunity to kind of educate through the exercise of naming something that's locally apparent to the individual. So they say, I have a trigger point, a knot is what I generally hear from my patients, in my trap. So they already have a connotation that it's something structural happening into that specific muscle that causes them their symptoms. So that's the local. And we're getting more and more evidence. Again, I keep referring to Stecco, but there are multiple. Robert Slipe and the fascial community that I've been spending a lot of time reading about is starting to get us some information of what's happening at a tissue level, at a fluid level, at a relationship level of multiple tissues. So yes, I agree that there's something that we could do to the tissue that could influence the mechanics of the tissue. But to answer your question, why I think that there's such a hockey stick, trajectory of these pain syndromes becoming more resistant and more obvious, is the central amplification of these danger signals. Is that yes, we have a knot. I'll take my mom as an example. She will just say, "Gosh, I got this tight knot. I'm just going to kind of breathe through it. I'm going to get through it." And she doesn't attach any significance to it. And I think over the last, definitely since COVID, there's definitely been an information overlay that is starting to lead to the catastrophization, amplification, the interpretation of those symptoms as being more than they generally are. So I think that combination of the local tissue, signal with the the interpretation from the central system, the brain in particular, and how it interprets it is leading to this phenomenon that is much more than just the tissue. And that's why I started this conversation saying, should we not be getting a little bit more information of how to interact with the nervous system to be able to downgrade or down-regulate the interpretive component of the experience?
Yeah. I have, if we're diving into theories of why, which I don't know if it gets us further along in the treatment room, but maybe it does. We know for sure, like I said, is, it's not the persistence of pain over time that just makes it chronic pain. It's the iterations that are kind of reverberating throughout the systems of the body and create a different experience when pain persists. But I think we see that, anxiety and depression is skyrocketed. I don't know if I haven't looked at it. I probably should. If it's on the same trajectory as pain, I know they're both going way up, and it's not just the U.S. So if we look at things like that, with a lack of movement, with information overload,
yeah,
we only have so much. Like, our neocortex is called neo for a reason. It is pretty new, and we don't have a whole lot of bandwidth. And I think when you compete with bandwidth, and then you have less of an experience in your body, less movement, right, which is definitely happening, and then we have an opportunity with like anxiety and depression for whatever, which again, that's factorial. It's not just depression, which is, I can't remember who I heard saying this, that he was like, if you went to a cardiologist and they gave everybody aspirin for every time they had a heart problem, that would be dumb, right? We'd be like, what are you doing? But he goes, that's what we do for depression. We just call it depression, and we treat it all the same. It's not the same. So I think when you put stuff like that together, and obviously there's other subcomponents and factors there, I think you overload the system, and then, like you said, it's pain run amok, the catastrophization. But I really think we were talking about this the other day because we had a little too much fun in Nashville this weekend, that a lot of people experience anxiety the day after like drinking alcohol. And there's definitely a physiologic reason for that. But a big reason for that is your experience gets cloudy, right, when you're drinking. And then the next day analyzation is when people have anxiety. Yeah. They're like, I don't know. And we're not talking blacking out. We're literally a couple drinks and stuff just gets fuzzy in your brain. Yeah. And then that's the anxiety. You're like, oh, and you may not recognize this, but you're like, oh, there's a mismatch. I don't know if that really happened. Then your brain's freaking out. Imagine your body doing that all the time because so much stuff's going on, little anxiety. And we know, look at a chronic pain questionnaire. How many things dance around anxiety or depression? That's right. And then you add in, you don't move enough to have your body help you figure it out from a, whatever we're going to call that, say, mechanoreceptive, proprioceptive, interplay dance. Mm-hmm. It's a perfect scenario. So then, our job is largely not helping people with anxiety and depression. Maybe it gets them moving so they can help with that, but that's not the main role. We're not going to get rid of cell phones and computers and the information news cycle that's run amok. We can get them moving more, and I think anybody that would disagree that pain alters movement, both in the way you do it and the amount, that is something I'll be like, you're flat out wrong. We know that. That's known. And you could be a 2-year-old and stub your toe and walk around like a weirdo until it like wears off, and you're like, oh yeah, I move different, and that could persist. Right. So I think that's where we got to be like, oh, okay, I can have an influence on pain, even though I'm not treating it. Now, how you want to go about that conversation, we already kind of got into that. Mm-hmm. Then I think we do need to help people have a different experience within their bodies. And from my perspective, that is largely interfacing with their body, not diving into past trauma and all. There's a place for that. I don't think that's my place. Mm-hmm. But yeah, that's kind of my take on it. And that stuff ain't getting better. Like all those scenarios. So like, we better start asking more questions of like, is it the same tools? Do I need to look at environmental toxins, even all these things that maybe makes it easier for a nerve to get sensitized? Like all these things dance in my mind of like, God, I hope I'm not missing something that I could like make my job a lot easier.
And you said it really well, and I think you were actually pretty eloquent as you described this. But just I want to dive further into this idea. Like what can we provide, or at least I can provide my opinion on maybe a starting point as it relates to taking advantage of touch as a biomechanical interface, but also as a biopsychosocial, going all the way back from the beginning. And I think it's important for us to give clinicians at least that type of insight, because I think we're inundated with all the biomechanical, effects, and I challenge everyone to dive deep into whatever category that you feel is science informed that provides you better insights on what that dosage may look like. But here's what I would argue is when you have someone that you might consider touch therapy as being applicable for them, but they don't tolerate it very well. I'm not one that believes that more pain will reduce your pain experience. So what I've done over the last 10 years is really started to dive into taking advantage of touch as a communication with the brain to be able to interact with that biopsychosocial component of the experience. So I do this, and I'll start with just a more of a brief description of how I interact with someone, and then maybe you could come up with some questions that might be pertinent to the discussion. But I'll start off with a less is more approach. It's actually one of the slides that I've had in my presentations for well over 15 years, is that less is probably going to be more for most people. But how do we actually test that? Well, we need to start with being more gentle. I was trained that it needs to be deep and it needs to be significant to be able to get whatever the effect is. And that may be true, but if I don't test the idea of less is more, how do I know? And so what I have been leaning, again, pretty heavily towards is some of the research coming from Diane Jacobs from the dermal neuromodulation group that has just been talking about leveraging the one tissue that we can access, which is the skin. So when you're interacting with the skin, which is a manual therapy technique, it's very light, right? So we're talking about as light as it takes to be able to get contact to the skin, to be able to manipulate it in different ways. So I think it's important for us to take the human body like layers of an onion, and we start to kind of peel away at the onion to kind of find out which tissue that may or may not be involved here. And I think this is a great teaching lesson or learning opportunity for the patient as well, is that they come in with a preconceived notion that they have a gremlin in their tendon that they are experiencing as tennis elbow. So their thought is that it's at a tendon level, that the expectation is that I need to be digging into that level because they want confirmation that was the reason for their pain. But if I started off at the skin level and I educate them that I'm going to be peeling away at the onion, and this is exactly how I would communicate it to my patients and clients, that I'm going to start to peel away, and I want to see if we can influence your experience with this approach. And so it gives me the opportunity to actually interact with them with this less is more approach. And I work with a lot of athletes that they are used to deeper is better. So it's a great opportunity to teach someone. That's the cognitive component of the psychosocial aspect, is that I want to teach them that their experience might not be what they thought it was. So first tangible thing that I would ask anyone that's listening is potentially start to think about this less is more approach with your manual therapy, and start to kind of interact with the skin and underlying connective tissue. That could be, the superficial and deep fascia if you want to get deeper into the weeds. But we're talking about the most superficial structures that might be influencing their pain. That's my first kind of entryway into the system of using a manual therapy or touch technique. So I'll stop there and see if you have any questions as I continue to go further and further into the system.
Yeah, maybe less of a question you can build on this is, I taught the day after Greg Rose at the rehab diplomate last year, and he did a very SFMA motor learning kind of talk, and then I asked him, hey, will you stick around for my talk so you can critique it? And he goes, hey, I have to take off. So we were at dinner, and I just kind of gave him the 5-minute spiel, and mine was largely on, I called it the Tootsie Pop approach, right? Like, how many licks does it take to get to the center? A lot of us are just we're like the owl, 1, 2, 3, and like and I was like, the more I look at the research on peripheral nerve sensitization, because we know from a lot of these articles that I just showed,
That's right.
the peripheral nerve sensitization changes tissue tone, maybe creates a trigger point, whatever that is, changes joint range of motion, not purely based on the tissues changing, but there's something occurring around, whether it's feedback loops or something, with how that joint moves. So restricted range of motion, then obviously pain, right, with that. And then if that runs amok, right, neurogenic inflammation can occur, and you actually get a chemical soup to that. And I was like, if you look at a lot of the research, because now we're saying, well, a joint, maybe I don't have to go in and think that Wilson's law is a thing where I'm like treating the joint to get this, in, out. It's like you said, work on the candy shell and see if you can melt away at this thing. And Greg, I brought it up to Greg Rose in particular, and that's why I was curious. He goes, well, I think you're just treating pain. Like SFMA, we're looking elsewhere. And I go, what I'm trying to say is, I think even if you treated a global, like a kinetic chain, like I'm just making something up. Somebody has low back pain because maybe their mid-back's stiff and they have to extend heavily at their lumbar spine. General biomechanical hypothesis. That sometimes, because centrally mediated stuff has started within the first 12 hours of that peripheral sensitization, that thing will stay pissed off even if you get your T-spine moving better and mechanically offload. And he was like, nah, I think you're still just treating the side of pain. I was like, okay. So my thing to you is, you're a movement optimist, we're trying to get people moving. So then the approach, just so people can get the nuts and bolts with, obviously not teaching a seminar, is this a global touch approach? Is this, hey, I'm calming down locally where they're having pain? Is it based on a diagnostic approach? You're like, I'm not doing touch intervention where they hurt. I'm doing it based on findings, whatever that audit system or diagnostic system is.
Yeah, so let's start there. So locally, and I'll just kind of share with you how I would approach it. If someone's coming to see me and they have a spot, I'm going to focus my attention at least centrally around that region of complaint. I do have enough information, and I can probably tease it out to identify that the mechanical insult to the tissue might be something more distant, but we're starting where I'm trying to create this therapeutic alliance, and I'm trying to meet the expectations where they lie, and I'm going to start with the local area. So knowing that, I'm going to be more kind of local to the area of complaint for that individual. If we're talking about skin as like my first interface as a manual therapist to start to impact their experience, I would argue, I would echo what Greg said, is that I might be chasing pain, but I'm chasing pain to gather more information. So here's what I would suggest someone would think about by taking this approach. I'm using the skin as the initial, I love the candy, of the system, is that the candy shell is going to be my interface. And I'm going to be kind of pulling the tissue in different directions, gathering information. Does this make it better, worse, or no change? And let's say I get a direction that gives the person a significant, relief in their symptoms. This to me is the neurological window that I just opened, and I might even argue a biomechanical neurological window. Let's say that trigger point or that area of complaint, whatever we want to call it, is an entrapped cutaneous nerve. This is what I spoke about at Fix in Malaysia, is that I'm arguing that some of the symptoms that we experience could be, something much more exterior or peripheral. So to a cutaneous nerve that's innervating the skin just in a sensory manner, that it's been entrapped somehow. And if I influence the skin in a certain direction and give them pain relief, I've mechanically altered the nature of that mechanical stress to that cutaneous nerve. So that's the local response. I find a direction. The dose would be the directional preference that gave that person relief. Great. But there's more to the conversation. Like, what is the interpretation that the brain is getting? This is how I'm also taking advantage of this touch stimulus to be able to interact with their map system, how the brain perceives that area, going back to what you just said in respect to your post, Nashville, experience. If you have a couple of drinks and you've kind of gotten a little smudgy of what the experience was, your anxiety goes up. The same thing is true in our own body. I've shared this with you and many others, that we have a map of our body as well. And if that map is smudged in any way, which is very consistent with trigger points and other pain syndromes, that an area that's experiencing pain the representative map in our brain, in the somatosensory cortex, is challenged within minutes. We're not talking hours, days. Within minutes, the clarity of that area of the body can be compromised. And look up the Neuroorthopedic Institute from Lorimer Moseley and David Butler. They've been speaking of this for many, many years. So my global approach of using the skin as an interface is using my touch to be able to illuminate, to shine a spotlight on, to decrease the blind spot of that specific area, to give the brain the information that it's looking for, which is where is that body part in space. And so
Can I throw the straw man in while we're here?
Mm-hmm.
So the argument that gets purported on social media and other places is, why not just move that area instead of you rubbing the area?
That's beautifully said. And I would agree that movement is the goal, especially if they're coming in, as we've been saying, with some type of meaningful movement goal to get back to. Absolutely. But you said it again perfectly right, is that if pain is limiting their ability to explore that movement in a functional manner, can we not entertain the idea, if I can minimize the threat in that tissue by illuminating that part of the brain, as well as potentially offloading a component of the mechanical irritation to that nerve, I'm accomplishing what we're all looking for, which is, let's get my symptoms to a level that allow me to explore movement. But that is only one component. That's proprioception, right? We need to influence the exteroceptive, map. And we also have another one that many aren't talking about, which I know you and I have talked about, is the interoceptive map. What is this new experience that we've just provided someone by literally tugging on their skin, that I gave them pain relief and the ability to move in a more functional way? What have I done to their interpretation of that experience now? I potentially added another context that they could start to leverage when this symptom might reappear at another date. So I want to stress the point that movement is critically important. But if pain is altering that movement, I will chase pain, and I'll do so in a structured way to give the person information to say, yeah, I don't believe that this was in your trap. I believe that it was something more superficial, and lo and behold, you can actually manage this on your own moving forward, because I could show you how to do this. So I'm leveraging the experience to give them more information and more tools to be able to be more self-autonomous moving forward in the future. So I'll just just step back. I'm touching them to potentially offload a mechanical reason for their symptoms. That might be cutaneous if I'm using the skin as my interface. If I didn't get the outcome, I could start adding more compression, more stress to the tissue to start to impact other connective tissues or other tissues that may or may not be involved. But I'm not going directly to a muscle because some textbook said that a trigger point is only in the muscle fiber. I need to respect the fact that it might be in multiple layers of tissue that are competing for that space in the brain. So I'll stop there and see if you have any questions on that.
Yeah. So I always I'm always in my mind trying to think, well, what would somebody else be thinking that's like outside the conversation that maybe has a different point of view?
Sure.
I think sometimes in our world, what people lack in looking at the overlap and all these different methods and ideas, that's what they lack, because they haven't seen enough. So like the Dunning-Kruger effect, whatever we call it, like they haven't seen enough to realize, like, oh my God, like what he's saying is actually something I do. I just don't know enough to realize like that there's massive overlap. So one of those huge overlaps, and I think it's why, I'm biased in this arena from a methodological, or I guess it's a concept, is like DNS. If you think about what you just said, it's a lot of closed chain stuff. There's a lot of ground contacts of the skin, right? The exteroceptive, candy shell is being interacted with. Mm-hmm. You're also working a lot on breathing and intra-abdominal pressure, which is immediately taking the interoceptive kind of, and they have all these mechanical, explanations. Yeah. That's happening too, right? Yeah. It's not that one's right and one's wrong.
That's right.
And then you're moving, right? And then it's also hands-on. You're touching whatever you're going to say. You're touching points. You're guiding them. That in itself is everything you just said. It's just different. And then somebody will be like, well, I do DNS. And then you're like, yeah, I'm doing all the exact same stuff. Just, right. Maybe it's not is quite as specific. Maybe the thought process is different. But I think the best in the world are the people that have seen enough or realized enough, because like those are the people that if you ask like a Paul Hodges like what they think about something, a lot of times like, yeah, that's right, and you're like, well, there's no rebuttal, and it's like, well, no, it's right because, and then they would like, you just, it's a little bit different here, it's a little bit, generally it's all about the same. And I think we are arguing largely, not arguing, a lot of us are like, oh, that doesn't work, and then if you looked a little further, you'd be like, oh, it's not only right, aka it's actually the same as what I would do, whether that's hands off, hands on. So I wanted to bring that up because if we move from, okay, local touch, I'm trying to maybe the term desensitize is bad because I use that a lot. Maybe it's reintegrate, remap. I don't know. What word would you use?
I moved away from desensitize as well. Now there is evidence to indicate certain touch stimuli from sustained pressure to shear pressure to vibratory touch, which has been a hot topic lately of potentially overloading the stimulus to potentially gate the other, which is very common when it comes to the pain gate theory of stimulating mechanoreceptors to gate the nociception. Yes, but I'm moving away from that because, again, from what we're learning is that touch is much more than just desensitizing. It's an information pathway that we're providing. What isn't done when it comes to the touch stimulus, in my opinion, is, again, most touch therapists, manual therapists, are operating on the tissue because that's how they've been conditioned. I'm now asking the individual to interact with me, to give me their perspective of what they're feeling within their body. Why is this important? You just brought up breathing. We breathe unintentionally, to be able to survive. But when someone brings attention to your breath, just anyone that I always sit up straight and take a deep breath in. Everyone kind of is got a central, goal of saying, I'm now going to pay attention to this breath because I'm now being conscious, which is so cool about breath is that it's generally unconscious until we make it conscious. So let's take advantage of the conscious exercise. I actually leverage the breath for that purpose. I'm going to be touching you, and I want you now to pay attention to your breath. And anyone can do that. I'm going to pay attention to the inhale. I might give them some analogies or metaphors to kind of get them to think about certain things. But my exercise is I want them to interocept, which is what breathing is to what you feel inside, which pain is a component of interoception. I want them to interact with that experience. So my touch is touching them exteroceptively on the outside of the body, the candy shell. And I'm now asking them to interact with the inner environment, and now I'm asking them to again, be curious. It comes back to my curious muscle of teaching them how to interact with the sensations that they have, breath, pain, other sensations that they experience within. And this is where the secret sauce is. This is where the melding of the mechanical touch to the biopsychosocial, influence, I can start to now give people the ability to better self-regulate the sensations that they have within. And I'm doing so through the exercise of touch, saying, I'm touching you. Where am I touching you? Exteroception, the outside of my knee. Is your leg moving or not? And they're like, not moving. Let's have you start to now kick the foot out. Is it moving quickly or is it moving slowly? Now I'm asking them, I'm not just asking them to move, I'm asking them to give me feedback of what they're experiencing within. And then I get more complex, right? So now I'm asking them, is the sensation increasing your temperature or decreasing your temperature? Do you feel like you want to lean into that movement or shy away from it? Getting a little bit more complex in my questioning, not requiring an actual specific response. I'm just asking them to interact with their inner environment. And this is the part that I think is challenging for a lot of mechanics out there, that they don't feel comfortable interacting with what someone's feeling. Even though we deal with it, we swim in it every day with the patients that we deal with, but we're not interacting with them. We're not asking them to interact with themselves, which is within their scope, right? Of when we talk about our scope of practice, it may not be appropriate for me to interpret what someone else is experiencing, but for you to interpret your own sensation is a critical gift that we all have. And the better we interact with that, the sensation from breath, that's just a normal feeling that I get when I take a deep breath in. Just like pain is a normal sensory sensation that we should have, that's telling us that we might want to change our posture, that we might want to change the way that we're doing a movement, that this clinician can actually help me perform in a more biomechanically, functional manner. I struggle. I struggle with the idea that we are one or the other. We are working with a human being. We're putting our hands on someone to interact with them mechanically, yes, but I'm suggesting from outside in so that we can better understand which tissues that we're interacting with. And then psychosocially, this is the part that I was never taught. How do we actually layer that in? Because we always talk about biopsychosocial, but no one gives me the roadmap, as I said earlier, of how to layer it in. This is my attempt to layer in the psychosocial by asking someone to give me their interpretation of what they're feeling within.
Yeah, I've never quite thought about it. Like, I mean, I knew it, but like putting words around, like we're like doing this, you're like the uncle playing shark with the kids in the pool of pulling people out of their subconscious pattern, right? Like maybe somebody, if we want to have this conversation, like they started moving their arm a certain way because they had pain, and now, we're like, hey, that you got to reorganize, sensory input, and then maybe there is a mechanical component that we need to change, or maybe it's just, need to be able to move without pain. I mean, there's a conversation there too.
Of course.
We're pulling them out of their subconscious into the conscious, right? That's the awareness piece, the interaction. But then we need to like let them go back into their subconscious. We want a subcortical pattern if we're talking mechanics, right? That's that. Hey, if we think there's an aberrance in the movement that's caused it, and like, why would you do that? Because this is my question. I'd love to hear your thoughts on this. My question is, and I know what some research would say and other clinicians, but like, if we get into a compensatory pattern, if that's something you agree with, like I move a certain way because I had an injury or pain or whatever, and we know from motor learning that you never get rid of an engram, right? It's there, and you just can form a new one, but you can't get rid of the one. Why in the world would you not go back to the non-painful one by yourself? Mm-hmm. That's never made sense to me, because that's what we're doing that's what we're supposedly doing. If there's an ideal movement around your knee in a squat pattern, and you've moved away from ideal, if that's a truth that can be talked about, why on earth wouldn't the subcortical power that's running most of our day, or subconscious power, say, hey, the pain's gone, bud. Like, let's just go back over here where it was non-painful to begin with.
I wish I had a more, none of my answers are specific. I'm realizing that as I give them. But this is actually really kind of supporting what I've been saying, what we've been saying, that we're talking about a messy, gray, complex system. So I don't think that there's a specific answer. If someone from the social media world wants a specific answer, they should go and seek it themselves, because I think they'll be continuing.
They should also be in a different profession. I mean, it's not going to happen here.
You get into a pharmaceutical, maybe. But in this case, we're talking about something that's a lot more complex, and I accept that. So to go back to what you just said, is that I'm trying to. I just listened to Wada. Oh gosh, how do I forgotten his name? From Rethinking.
Yeah.
I can't believe I've forgotten his name.
I'll find it.
It'll come back to me. Anyways, he was known to be giving a specific architecture of a squat, for example, that your feet had to be turned at a specific range of motion. So that's information that's been provided, that's been sent out to the ether. People absorb, and they say, well, I need to have my feet turned out at 15 degrees. Even though my knee bugs every single time that when I squat, I have pain in my knee. When I do it biomechanically sound, I think that that's a component, just going back to what I said before, your beliefs and expectations influenced your experience. And so what I have to do is condition someone to say, I don't believe that there's a one size fits all to anything. Your ability to be variable in your movement is what's going to give you the tapestry of choices that you need to make according to the goal that you have. That follows the ecological approach to movement. is that it's the athlete interacting with the environment and the goal. And so I always go this with my patients. It's like, yes, I know you've been told that 15 degrees is ideal, but I don't believe there's an ideal movement. Let's explore your body through movement with different positions, for example. So the exercise is movement, proprioception. I'm going to go back to my three satellites or three maps that we have. I'm going to have them explore movement with different positions. So the intervention that might be exploring the movement, noticing that at 10 degrees versus 15 degrees, they have less pain. And I'm going to start to use my education of that might be more appropriate for that individual for that specific task. Great. What if I couldn't get their experience to be more favorable? I might use touch to be able to influence it. And I'll just echo what I just shared with you a few minutes ago. So the exercise is retraining the sensory expectations and interpretations to be able to make a change. I don't think that is veering away from what science is telling us, nor am I doing something that's unsafe. I'm allowing someone to explore their movement within their mechanical milieu to be able to influence something that they want to get back to do. So I have no problem with that.
Yeah, I think, believe it or not, as messy as this has been, we got a huge actionable step, though. I think a lot of people would agree. Some people disagree, and then some people maybe just don't know. Like, if you start in the periphery, whether it's, we have a graded way we go about that, right?
Yeah.
You're like, I'm being very specific about dose and depth. And, if we went into Stecco land, like speed and duration and all, there's a precision to that it makes a difference. I would agree with that, and I would hope more people, if they don't think that's correct, would look into that. Largely with a lot of stuff that you've taught. Second, there's a movement component where, as you said, as you get to ownership, is like you can use modifiers, right, to compete with the pain experience to get them to experience movement, but the experience piece is what it sounds like a lot of clinicians are missing, whether it's a comfort level with how to interact of, hey, what are you experiencing? But what's interesting is that talk that Greg Rose gave the day before I did, the one slide that I talk about now more than anything is his motor learning slide with the 7 bullet points of like just very, very, very easy motor learning concepts that every clinician almost to a fault doesn't follow. Like as simple as asking somebody, instead of saying, hey, we want to do it like this, and then you give them what they're supposed to feel, right? Or, hey, we want you to feel this.
Yes.
You instead say, what do you feel? Which is parallel, again, different concept, motor learning for like learning a golf swing, but you're saying if somebody's had an aberration of movement or pain or both, we could also say, what are you feeling now? Is your leg moving fast? Are you warming up, cooling down? So again, now we're seeing an intervening, path of like, oh God, if I'm gonna, coach somebody's movement or change it or, have an interaction, scenario, that feedback, that experience becomes the key. And that literally, if we wanted to take that to the highest level of performance, now it's the same thing. If we get back to Wayne Gretzky, sensory motor integration, somebody that had feedback that was out of this world, right, in terms of what he's feeling and what his, cerebellum and cortex is picking up, way different than mine. I know, I'm not in the Hall of Fame, and I'm not, in any sport. So I think that's beautiful that you're like, hey, yeah, there's a process. We can start with touch. We can use touch. We don't need to deny the touch, but we need to be precise. We need to get them to move. We need to have them ownership. And maybe the thing that's missing is we're supplying the experience for most of these people through our, what we're doing with our hands, but we don't know their interpretation of anything. And then we have our expectation of what they should be doing from movements and exercise and how they should do it. And we never actually ask them, besides maybe, how do you feel? Do you have less pain? And then we're like, see you later. I'm good at my job. And you're like, oh God, I missed the biggest piece of the puzzle.
This is where I would agree with Greg's that most people, and I fell into that trap as well, but I'm not chasing pain. I'm chasing their relationship with pain. And I'm chasing it as their guide, their shepherd, to say, I'm using my touch because I know you expect that my touch is going to be more therapeutically laced with some type of magic, because that's what they're conditioned to come see their doctor for. it's our prescription in our hand that they come in with the expectation. So I'm leveraging that opportunity. But if we're not taking that opportunity, and this is where I do agree with the majority of the evidence-based practitioners, the non-manual therapy practitioners, that if you're only providing the input and not providing the opportunity for someone to learn, then yes, you are fostering self-reliance or reliance on your therapeutic intervention. But if you're using this as a medium to be able to have someone extero and interocept, and then eventually, hopefully, propriocept in a functional way that meets their goals and their environment, I don't understand why we're arguing this idea. It's semantics of Greg saying you're chasing pain. That's a negative connotation that I would have interpreted, and say, well, gosh, maybe I need to rethink what I'm doing. I was like, no, I stand true to the message that my touch is an opportunity to make a change to their experience, but more importantly, it's an opportunity to teach their psychosocial system that they have control of this. And so that's in my opinion, a great way to kind of just tie this into a bow and say, let's start there. Maybe kind of setting the stage for part 3, which would be, let's start introducing some other competing opinions and say, hey, we've come, I'm maybe placing this on you, but I'm saying we came to an agreement that we think that this is the starting point that we might be able to kind of come to an agreement on, and then we start to kind of layer the evidence to support this over the next 10 to 50 years. So that,
I think what's tough for people is all you and I, if we said, hey, we're going to agree, all we're agreeing on is like a framework,
That's
right? And frameworks are literally scaffolding for a reason. Like you put stuff on them. I think that's what our profession, I'm saying our profession, all the way out to strength and conditioning, all the way down, massage, whatever it is, there's lacking a major underlying framework because it started at basically interventions, right? Like all these things started with like acupuncturists teaching acupuncture, chiropractors teaching chiropractors, and it wasn't like, it's not quite physiology where we go through the systems and we're like, hey, these are all the systems. These are how the systems interplay. And then that interplay of systems can become damaged or pathologized. And then we're over in pathology land. I think we kind of forget that like we don't have a great framework yet because it's complex. And I think that's where we can leave this for sure is like, we're not saying this is the framework. There needs to be a framework. And I think we're getting closer and closer to understanding, hey, there are better ways to treat the systems of the system. And maybe the fall off is when we have to treat the system, right, as an entirety. And that leads back into that BPS, kind of approach. But I think that's what I would love to see is like more conversations with not competing to create adversarial conversations that are clickbaity and stuff. Like we need competing interests because you and I do agree on all that stuff. And as much as I love talking to you, I could learn from you all day because you just know stuff that I don't, but we're not ever going to come probably largely to a different conclusion on something because I don't know enough different stuff from you. You know more than I do. But like, I'm also not approaching stuff from, well, I do this over here. Like we practice pretty similarly and you kind of have a subset and I have a subset.
Right.
See, I think our profession needs not less seminars that are, methodological. I mean, we just helped teach one this weekend. We need more conversations that are across the scope. And I think I don't think a lot of people in our field are, the tops, the ones that we look up to are open to it. Some aren't because they don't want to be thrown off, right? They want to have their belief kind of stronghold because that's how they've created their identity.
That's right.
But like the best in the world are always willing to change their mind. I think we need more of those people up on a stage or on a conference or on a podcast, just having discussions and seeing what comes of it, and maybe they do disagree and maybe that leads to different research. Maybe they do agree on things. Like that's not the point, is the conclusion is not the point, it's conversation.
That's right. This is exactly where, a lot of people will close the book. I'm saying you can close the book, but put a placeholder in this spot where we can start to kind of rewrite the, subsequent pages. I think I'm actually more excited with the conversations that I'm seeing now. It's frustrating to see that two sides, and this is actually very consistent with just the environment that we live in globally now, is that we can't come together. Being the Canadian in me is that I always felt like I was the centrist, saying I get both sides, and I do get both sides to this conversation that we're having today. But can we not come together for the benefit of the patient or client that we work with? Can we not come to, this is like to the scaffolding approach? I'm not expecting you to have bamboo versus steel. You can decide what that scaffolding looks like, or how it's built, but I mean, the scaffolding is still the same. And I think we're getting closer to that. How close, I don't know yet, and how comfortable are people going to be to move away from their central stance? We'll see, but I can only hope, and that's just being a curious observer.
Yeah, that is the hope. So, I mean, we covered a lot of ground. Again, you and I said before we got on here that we had no clue where it was going to go, and that's, I mean, we kind of had a roadmap, but we ended up in a really good spot, like a really good spot that I'm proud of for a lot of reasons, because it does set up future conversations. It gets us, there was actionable things in there that, you know, clinicians and the layperson might, you know, latch on to, look further into, have in the back of their mind next time they have an interaction on either side. But yeah, the thing I would want to leave with, you know, talking about this, what seems dualistic, right? That there's just two. It's, I mean, that's all we see, right? So we know that's not the case. We go to any seminar on any given weekend. I mean, you might have one person that's like, this is all crap, or questioning everything, or they're so hardcore that's the only, you know. I don't think that's most people. Like the moderate middle is kind of, you know, the general, and we just don't see that. But I'm telling you right now, the polarized ends of our profession, that's how we're going to push it, though. Those are the people. Right. If you're trying to better the profession or yourself or your patient's experience, those are the people we need to talk, because those are some of the people they're going to see, but also if you can crash those people together and see if things do overlap, or if there are parallels, or if they are greatly different, or why they think that way, right? That's a huge one. That's where you start to be like, oh, okay, I've never thought about it like that. Like, I've never even heard, like, that's what I'm interested in. And, you know, the tough thing is those experiences don't exist. Like, that those conversations don't exist. It's a lot of, I don't want to say echo chamber, but like,
they're monologues. They're monologues.
Yeah.
Monologues are what we're seeing in social. We're not seeing dialogue. Our dialogue is kind of set up, not in our favor, but to be able to kind of move us on a specific path, because we're both comfortable with this path. But we need dialogue which has significant divergent paths that allow us to figure out there might be a kind of secondary road that we just haven't thought about. So that, I think this is the next step. Is I'm kind of setting this is the stance that I believe to be true right now. I've actually had 2 decades of testing it. I want someone, not necessarily equally, but I want someone that might argue that is the right path, and I want us to come, on a platform where we can have like these types of conversations under challenge. Because I agree with you, complacency of your specific direction isn't going to get us anywhere. We have to now mash those two together to see, can we actually come to an agreement that actually is, again, to the benefit of the patient and client. Absolutely.
Well, as always, you're awesome to talk to. Like I said, I learned something every time, and I'm just glad to be in the same profession as you. And you got anything coming up? Or you teach anywhere, travel anywhere else? I know you've been all over Malaysia. You're heading to New Orleans to experience that.
But the next big one would be the Fascial Research Congress. Anyone that is interested in, even if you believe that it's complete, nonsense, which I hear quite often when it comes to the fascia system and its relationship to pain and movement, I would challenge those folks to come to an event like that, especially it being stateside this year in New Orleans. I wish I had the date, front and center, but it's in August. Might be July. I'm not the best. I should be able to know this, but consider the Fascial Research Congress as an opportunity to broaden your scope of what you do as a manual therapist.
Yeah, very cool. Well, again, thank you. And maybe with my little Nashville endeavor with Dr. Lance, maybe we'll set up one of these conferences in Nash Vegas and do some of this colliding or competing ideologies and have some fun combos. But I would like to see more of that stuff. Like I said, some of the bigger events that people have always loved of, Stu McGill and Pavel and these different people on stage, like those have been things that people talk about forever for good reason.
Yeah. I'm game, so count me in. As always, I love talking to you as well, and I can't wait to the part 3.
Cool. Thank you again, man. Appreciate it.
Take care.